this video, we will going to continue our physical assessment part 5. This part 5 includes male and female genitalia and the rectum. So first, ma'am, before we proceed to your assessment, let me ask you first some question. So, ma'am, kailan po ba kayo nag-last menstruation? Last week? Okay. Meron po ba kayo hanggang ngayon? Okay, wala na. So, ma'am, may nararamdaman po ba kayo na any abnormalities like po ng pagmamaga or pain? Okay, that's good. Sa tuwing umiihi po kayo, ma'am, meron po ba kayong naramdamang masakit or wala naman? Okay, that's good to hear. Thank you sa answer, ma'am. Then now we will going to start with the assessment of our female genitalia of our patient. So first, we will assume that this is our female client and she is in a lithotomy position. Lithotomy position is a back-lying position with feet supported in a stirrups. The hips should be in the edge of the table. Then, we will apply gloves in her hands, but in my case, I already applied it and it's already lubricated. Then, we will first inspect the pubic hair of our patient, its distribution, amount, and characteristic of the pubic hair. So, we will going to inspect it here in a mons pubis area. So, the pubic hair of our patient is distributed in an inverted triangular pattern and there are no signs of infestation or lice or nits. So, next we will going to inspect the labia majora and the perineum of our patient. So, we will inspect the labia majora in this part. Here is the labia majora and the perineum of our patient is here. So the labia majora and perineum of our patient has equal in size and it is free from lesions, swellings, and excoriation. Then now, we will going to inspect the labia minora, clitoris, urethral meatus, and a vaginal opening of our patient. So we will going to do that by spreading the labia minora using our index fingers and a thumb. Here. So, as we can see here, this is our patient urethral meatus and here is her vaginal opening and here is her clitoris. So, we can say that the labia minora appears symmetric and dark pink and moist. The clitoris is a small mound of erectile tissue sensitive to touch. The normal size of the clitoris varies. Then the urethral meatus is small and slit-like, and the vaginal opening is positioned below the urethral meatus. Its size depends on the sexual activity or vaginal delivery, and a hymen may cover the vaginal opening partially or completely. Then now we will going to palpate the Bartholin glands for swelling and tenderness. So, the Bartholin glands of our clients are soft, non-tender, and drainage-free. So now, we will proceed with palpating the urethra and the skin glands of our patient. So, if the client reports urethral symptoms or urethritis, or if you suspect inflammation of skin glands, we will going to insert our gloves and index fingers into the superior portion of the vagina and milk the urethra from inside, pushing up and out. So, in our case, our patient has not reported any inflammations. So, as we palpate her urethra, we noted no drainage and the area are normally soft and non-tender. Then now, we will going to inspect the vagina of our patient. So, imagine that my hands has a speculum in it and we will going to unlock the speculum and slowly rotate and remove it. So we will going to inspect vagina as we remove the speculum. We will going to note the vaginal color, surface, consistency, and any discharge. So the vagina appear moist, pink, smooth, and free of lesions and irritations, and it also free from any colored or malodorous discharge. Now we were going to inspect the size of the vaginal opening and the angle of the vagina. So we were going to insert our gloves and index fingers into the vagina, and we were going to note the size of the opening and whether the lining of the vagina is tightening or feels dry. So now we were going to insert our finger and attempt to touch the cervix because this will help you establish the size of the speculum you need to use for the examination and the angle of which you insert it. Next, while maintaining tension, we were going to gently pull the labia majora outward. And we were going to note hymenal configuration and transections or injury. So, our patient has a normal vaginal opening that varies in the size according to her age, sexual history, and whether she has given birth vaginally. The vagina of our patient is typically tilted posteriorly at 45-degree angle and feels moist. Then now we will going to inspect the vaginal musculator of our patient. We will going to keep our index finger inserted in the client's vaginal opening. Then ask the clients to squeeze around our finger. Ma'am, can you please squeeze my fingers around yours? Then we will going to use our middle index fingers to separate the labia minora. We will going to ask the patient to bear down. Ma'am, I will going to separate your labia minora. Can you please bear down? So the clients are able to squeeze around my fingers, and typically the nulliparous woman can squeeze tighter than the multiparous woman. So no bulging and no urinary discharge. Then now we will going to palpate the uterus of our patient. To do this, we will going to move our fingers intravaginally into the opening above the cervix and gently press the hand resting of the abdomen downward. So ma'am, I will going to move my fingers intravaginally into your vaginal opening above the cervix, and I will gently press your abdomen downward. So I will be squeezing the uterus between my two hands, and we will going to note uterine size, position, shape, and consistency. Then we were going to attempt bounce the uterus between our two hands to assess mobility. So the fundus, the large upper end of our uterus, is normally round, firm, and smooth. Then the uterus are moved freely and it is not tender. Then now we will going to palpate the ovaries. So to do this, we will going to slide our intravaginal fingers towards the left ovary in the left lateral fornix and place our abdominal hand on the left lower abdominal quadrant. And then we will going to press abdominal hand towards intravaginal fingers and attempt to palpate the ovary. Then we will going to slide our intravaginal fingers to the right lateral fornix and attempt to palpate the right ovary. We will going also to note the size, shape, consistency, and mobility and tenderness. So, the ovary of our patient are approximately 3 times 2 times 1 centimeter and in almond shape. And ovaries are firm, smooth, mobile, and somewhat tender on palpation. Then now we will going to withdraw our intravaginal hand, and we will going to inspect the gloves for secretion. So, a clear, minimal amount of drainage appearing on the gloves from the vagina. So, now we will going to wipe the patient vagina so that she will feel at ease and comfortable. After that, we will going to discharge the gloves and apply clean gloves and lubricant. And now, let's proceed with the male genitalia. So first, before we start, we will ask some questions to our patient. So, sir, may nabatyagan ikaw nga any pain or katal sa imo nga penis? Okay. May na-notice ikaw nga any nga discharge? Okay. So sir, kung mangihi ikaw gasakit imo nga may nabatyagan ikaw nga sakit or any abnormalities? Okay, that's great. Thank you, sir. Then now we will going to. So first, we will assume that we are sitting on a stool and our patient are standing on us. Then now we will going to inspect the penis, including the base of the penis and pubic hair. So pubic hair of our patient is coarser than scalp hair. The base of the penis and the pubic hair are free of exploration, erythema, and infestation of any lice or nits, and the skin of the penis is wrinkled and hairless, and it is free from rashes, lesions, and lumps. Then now we will going to palpate for the uteral discharge. We will going to do this by squeezing by index and thumbs the urethral meatus of our patient. So the urinary meatus of our patient is normally free of discharge. Then now we will going to inspect the scrotum for appearance, general size, and symmetry. And also we will going to inspect the skin surface by spreading the regulated surface skin and lifting the scrotum as needed to observe posterior surface. So the scrotal skin of our patient is darker in color than the rest of the body, and it is loose, and size varies with temperature changes. And scrotums appear symmetric, which is left testis is usually lower than the right testis. Then now we will going to palpate both testes and epididymis between your thumb and two fingers, and we will going to note the size, consistency, nodules, masses, and tenderness. So testes of our patient are ovoid, approximately 3.5 to 5 cm long, 2.5 cm wide, and 2.5 cm deep. And it is equal bilaterally in size and shape. They are also smooth, firm, rubbery, mobile, and free of nodules, and rather tender to pressure. Then the epididymis is non-tender, smooth, and softer than the testes. Then now we will going to trans-illuminate the scrotal contents for red glow, swelling, or masses. So our patient has no swelling or masses. Then now we will going to inspect for bulges in inguinal and femoral area. So to do this, we will going to ask the clients to turn head and cough and or to bear down as if having a bowel movement. Then we will going to continue to inspect the areas. Sir, can you please turn your head into the right and cough? Okay. Sir, can you please bear down? So, the inguinal and femoral areas of our patient are free from bulges. Then now, we will going to inspect the scrotal hernia, palpate the inguinal hernia and inguinal nodes of our patient. So, to do this, we will going to ask the patient to shift his weight to the left for palpation of the right inguinal canal and vice versa. Then we will going to place our right index finger into the client's right scrotum and press upward, indicating the loose of folds of skin. Then now we will going to palpate the spermatic cord until you reach the triangular shape, slit-like opening of the internal inguinal ring. And we will going to try to push our fingers through the opening and, if possible, continue palpating up the inguinal canal. Then, when our fingers is in the canal or at the external inguinal ring, we will going to ask the patient to bear down and cough. So, sir, can you please bear down and cough? Okay, and we're also going to feel any bulges against our fingers, and then we will going to repeat procedure on the opposite side. So, bulging or masses are not normally palpated in our patient. And now, we will going to teach the clients to perform a testicular self-examination. So, testicular self-examination should be performed once a month. It is neither difficult nor time-consuming. A convenience time is often after a warm bath or shower when the scrotum is more relaxed. So first, you will stand in front of the mirror and check for scrotal swelling. Then, use both hands to palpate the testes. The normal testicle is smooth and uniform in consistency. Then, with the index and middle fingers under the testes and the thumb on top, roll the testes gently in the horizontal plane between the thumb and finger. Then feel for any evidence of a small lump or abnormality. Then follow the same procedure and palpate upward along the testes. Locate epididymis and a cord-like structure on the top and back of the testicle that stores the transport sperm. Then repeat the examination for the other testes. It is normal to find that one testis is larger than the other. Then, if you find any evidence of small pea-like lump, consult your physicians. It may be due to an infection or tumor growth. So now we will going to inspect the perineal area. So we will going to spread the buttocks of our clients. And inspect the inguinal opening and surrounding area for the following, such as lumps, ulcer, lesions, rashes, redness, fissures, and thickening of the epithelium. So, the inner opening appears hairless, moist, and tightly closed. The skin around the inguinal opening is more coarse and more darkly pigmented. The surrounding perineal area are free of redness, lumps, ulcer, lesions, and rashes. Then now we will going to inspect the sacrococcygeal area. We will going to inspect this area for any signs of swelling, redness, dimpling, or hair. So the area is normally smooth and free of redness and hair. Then we will going to inspect for bulges or lesions as Balsa maneuver is performed. To do this, we are going to ask the clients to perform Balsa maneuver by straining or bearing down. And we will going to inspect the inguinal opening for any bulges or lesions. Sir, can you please do a Valsalva maneuver? Okay, that's good. no bulging or lesions appeared. So now let's proceed with the last assessment, the rectal. So first, we were going to ask the clients to remain standing and to bend over the exam table. Then, we already changed our gloves. And now we start with palpating the anus and external sphincter of our patient. Sir, I'm going to perform an internal examination at this point. It may feel like your bowels is going to move out, but this will not happen. So I already lubricate my gloves and index fingers. And sir, can you please bear down? And as the clients bear down, we will going to place the pad of our index fingers on the anal opening and apply slight pressure that this will cause relaxation of sphincter. So the client's sphincter relax, permitting entry. Then, when you feel the sphincter is relaxed, we will going to insert our finger gently with the pad facing down. Examination fingers enter the anus. Then now, we will going to palpate the rectum by inserting our fingers further into the rectum as far as possible. Sir, isulit ko lang kayo na kandima. Next, we are going to turn our hand clockwise and counterclockwise, wherein this allows palpation of much rectal surface as possible. We are going also to note tenderness, irregularities, nodules, and hardness. So the rectal mucosa is normally soft, smooth, non-tender, and free of nodules. Then we will going to palpate the peritoneal cavity. This area may be palpated in men above the prostate gland in the area of semi-vesicles on the anterior surface of the rectum. We will going to note tenderness or nodules. So this area is normally smooth and non-tender. Then now we will going to palpate prostate gland. The prostate can be palpated on the anterior surface of the rectum by turning our hands fully counterclockwise, so that the pads of our index fingers faces towards the client's obliquus. And we were going to tell the client that he may feel an urge to urinate, but this will not happen. Then we were going to move the pad of the index fingers over the prostate gland and try to feel the sulcus between the lateral lobules. We were going to note the shape, size, and consistency of the prostate and identify any nodules or tenderness. So the prostate is normally non-tender and rubbery. It has two lateral lobes that are divided by the median sulcus. The lobes are normally smooth, 2.5 cm long, and heart-shaped. And now we will going to withdraw our gloves and index finger, and we will going to inspect any fecal matter on our gloves, assess the color, and test the feces for acute bulb. So the stool of the clients is normally semi-solid, brown, and free of blood. We will going to provide a towel or wipes for unrectal area. Then we will going to discharge our glove. And lastly, we are going to do a aftercare of our materials or instruments. We are going to spray alcohol on it.